This is Michael Smith of MedPage Today. I'm in Vienna at the International AIDS Conference, where a survey of HIV patients around the world reveals some disturbing gaps in their knowledge, which possibly reflects the lack of interaction, perhaps, with their physicians. To discuss the issue, I'm here with Dr. Jürgen Rockstroh of the University of Bonn. Dr. Rockstroh, welcome. This is an interesting study. How was it done?
So this is a treatment awareness survey which was sent out to around 2,000 participants globally. So I think one special thing about the program is that we're actually reaching out to Asia, to Africa, in Europe, also to Russia. So, you know, countries where you would expect that there are some regional and geographical differences in some of the baseline characteristics as well as the responses to the survey. And the survey was done in different forms. So in some countries it was done face-to-face, in some countries it was done via internet, and others was just paper questionnaires. And the majority of the questionnaires were filled out in Europe, I believe. It was like over 1,000, and then North America was 200, and the other continents also roughly around 200. So Europe clearly constituted a big part of this survey.
Now, the survey is looking at how doctors and patients communicate, and sort of what they know each, what they're learning about each other. Is there anything? What does the survey tell us about how HIV patients and their doctors are communicating?
Well, I think the survey, first of all, tells us a little bit about differences in patient groups, and obviously transmission risk group for HIV is different. The epidemic is different in different countries, and it allows us to see a little bit how people feel with their therapy, what they know about their therapy, about things going along with the therapy. And I think one of the things we see change in HIV medicine is that we're becoming aware that persistent inflammation, HIV-induced changes causes comorbidities. So one of the big, questions here was, are people having comorbidities and are they aware of that? Mm-hmm. And so there is a substantial number of patients, over a quarter, who have comorbidities. And if you look at the interaction between physician and patient, then you find out that most of these comorbidities have never been talked about. So if you take, for example, hepatitis C, which 17% of the patients had who were in this survey, at least half of them never talked about that with their doctor. Now, that obviously raises some questions because there is a treatment for hepatitis C out there. So I think we're probably not doing enough in addressing all of these comorbidities, although we know that today the major reason, other than from those patients who present late and still develop AIDS-defining events and die from these events, I mean, the main reasons for dying today as an HIV patient is liver disease, cardiovascular disease, and non-HIV related malignancies. So if you take into account, you would think you have to talk about smoking. That was a part of this survey. We asked who was smoking and did you ever talk with your physician about smoking? And surprisingly enough, half of them never talk about that, although we know that this is the most severe risk factor for subsequent development of cardiovascular disease. And I think that's what we're trying to get out of this survey, because as physicians you also get a little blinded, and it's sometimes good to get a mirror to see, well, the patient, at least even if you think you talked about it, at least he never perceived as if that was an active component of your interaction. So I think that's where we're trying to get at, is that we have to get a more individualized approach, take into account the comorbidities, and remain persistent in checking on these issues. Mm-hmm. And I think that's something we want to change by these results, mm-hmm. I guess.
I guess one of the things is when a patient comes in for the regular checkup, does there tend to be just a focus on the disease itself, the viral load, the CD4 count, those sorts of things, and if they're fine, that's it?
Well, I think you're absolutely right. I mean, if you have 20 patients waiting for you in your waiting room, and the patient comes in and has CD4 above 500 and the viral load is undetectable, as a physician, you're likely to say everything is great, right, isn't it? But you're not, thinking of other things. And I'll tell you what we did in our clinic, for example. We now have introduced a bone screening. Why? There are more fractures in HIV patients, so there are international scores called the FRAX score, in which you can assess the risk for a hip fracture in the near future. But by doing that, you have to ask, is he smoking or not? You realize that you haven't talked about that for quite a while. So by filling out the questionnaire and the questions relayed, you suddenly realize that you have never talked about his family history of cardiovascular disease and other issues. So it is helpful to implement certain screening tools into your daily practice, because otherwise you're sometimes really left with saying, HIV is fine, But that's not what we're really worrying about these days. We're worrying about the accelerated aging and the complications for the organs, which is deriving partly from the drugs we're giving to the patients and partly through probably immune activation, which is present even in the setting of suppressed viral replication.
Okay. We'll conclude here because there are some areas in which you would think most people would understand the situation. You'd expect to get 100%. I noticed one of the questions was about, is resistance to HIV, is HIV resistance a good thing or a bad thing? And worldwide, most people got it right. But in North America, the percentages were, I think, 35 and 75 or 25 and 75. It's frightening that a large percentage of people, after all these years, think that maybe HIV resistance is a good thing.
Yeah, and I think that highlights there is a need for continuous education, and and things also tend to develop over time. Things tend to be forgotten. So I think maybe if that was talked at the beginning, for example, you start therapy, you do a resistance test prior to starting therapy to make sure that you give active components, but 5 years later you just forget what that's all about, right? Mm-hmm. And I think we need to refresh, because that also shows the importance of adherence. And I think one other finding of this study was that the probability of missing doses of medication increased with extended duration of time. So the longer you were on therapy, the more likely you were going to have an episode where you forgot therapy. But adherence issues can contribute to the emergence of resistance. So to keep that awareness that resistance is bad and not good, what 35% thought was the case, I think reiterates that education is something which has to remain and can't just be done one time, but we really need to follow up on all these issues.
Good lesson for doctors and for patients. Dr. Furstrick, thank you. In Vienna, I'm Michael Smith, MedPage Today.